Physician, when you are planning your drug or prescribing a drug, you must be sure and you should know what dose you have to prescribe it, the infusion that you have to plan, monitoring and reassessing simultaneously. Let's look at this with an example. There are two sets of patients and you prescribe meropenem 1 gram IV 8 hourly. Now, there is one patient who is in sepsis and septic shock, has augmented renal clearance. So this would result in subtherapeutic troughs. So your dose would not be adequate. Similarly, there's another patient who's an elderly and has established an AKI because of his presentation or his infection. Now begins to develop or starts having neurotoxicity risk. So, sepsis resuscitation increases volume of distribution for hydrophilic antibiotics. Vasopressors, edema, hypoalbuminemia, and organ support make exposure unpredictable. So, your prescription should be specific and it should specify the loading dose, the infusion duration, maintenance interval. You should monitor the renal function of the patient and always have the monitoring plan in action. Now we are going to look at the pharmacokinetics and dynamics from an intensivist perspective. Special dosing strategies in patients with sepsis, those with augmented renal clearance, AKI, those on CRRT. Then what special dosing you need to consider in obese patients, and a little bit about therapeutic drug monitoring. So pharmacokinetics. Pharmacokinetics means what the body does to the drug, and dynamics is what the drug does to the organism in the body. So your pharmacokinetics would explain exposure and dynamics would explain the effect. Now, in pharmacokinetics, there is volume of distribution which would be larger in shock, edema, fluid burns, patients on ECMO, and clearance can rise in patients with augmented renal clearance or fall with those with acute kidney injury or liver dysfunction. And there are certain drugs which are protein bound. So hypoalbuminemia would increase the unbound fraction and outprint clearance of the drug. Tissue penetration is another aspect. Remember that there are certain drugs which do not have effect, do not have tissue penetration in certain organs of the body. So when you are prescribing an antibiotic for your patient for a specific site, you need to remember the site for which you are prescribing and writing that antibiotic. And of course, there's an aspect of biofilm. So you have to keep that in mind as well. A little bit about the basics of the antibiotic properties. Now we have hydrophilic antibiotics which are water soluble. They stay mainly in blood and extracellular fluid. And then we have lipophilic antibiotics which are fat soluble, so they enter tissues and cells more easily. So your loading dose follows volume of distribution and maintenance dose follows clearance. Now, hydrophilic drugs like your beta-lactams, vancomycin, aminoglycosides, colistin, and phosphomycin, they are low protein. They have low protein and lipid binding, so they would have poor intracellular penetration, large effect of capillary leak, edema, and fluid loading. So, increased volume of distribution would result in decreased concentrations of the drugs early, and because most of them have renal clearance, so that is what drives the maintenance exposure. And you would need to modify their doses in maintenance phase based on the patient's renal functions. Then in lipophilic drugs like the macrolides, fluoroquinolones, tetracyclines, rifampicin, and azoles, there is large tissue and cellular distribution. They often they have better lung and intracellular penetration, and they are least affected by extracellular fluid expansion. They have hepatic metabolism, so you do not require any renal dose adjustment. However, if the patient does have a liver dysfunction or any other liver disease, then you may have to think of an alternative therapy. And how do you bring this into practice in your day-to-day bedside prescribing in the ICU? For hydrophilic antibiotics, you start with full adequate loading dose. You check the volume of distribution risk in patients. like those with edema, ascites, pleural effusions, burns, sepsis patients. Then you check the clearance daily, measured on the creatinine clearance, augmented renal clearance, those who are developing AKI or had AKI, and if the patient has been put on renal replacement therapy. For beta lactams, preferred is extended or continuous infusion when the risk is high, and use therapeutic drug monitoring not just for vancomycin but for aminoglycosides and beta lactams wherever it's available. Your lipophilic antibiotics, when you're prescribing, you check the baseline liver function always. And since you know they penetrate the tissues better, so obviously they would be available better with patients with such infections. But you must remember to monitor toxicity like QT prolongation, hepatic injury, marrow suppression in patients wherein you prescribe the lipophilic antibiotics. Now, a very important aspect of the PK/PD target is that different antibiotic classes need different exposure targets. So the antibiotics can be time dependent, concentration dependent, and exposure dependent. Now, time dependent antibiotics like the beta lactams, the concentration dependent antibiotics like the aminoglycosides, and exposure dependent like the vancomycin or fluoroquinolone. So, what is the basic? How do time dependent antibiotics work? The time dependent antibiotics efficacy is based on the time above the MIC. So, when you have a patient in the ICU, you want that it should remain 100% of the time above the MIC. And a patient with severe infection, you want the drug to be 4 times 100% of the time above the MIC so that it is effective. So that is why in time dependent antibiotics like beta lactams, you want extended and continuous infusions. And in concentration dependent like aminoglycosides, the efficacy is based on the uh, maximum over the MIC. So that should be at least between 8 to 10. So you want high peak levels. So once daily high dose is sufficient in concentration dependent antibiotics like aminoglycosides. Then exposure dependent like vancomycin or fluoroquinolones. So the efficacy depends upon the AUC over MIC. So for vancomycin, the area under the curve 23 over MIC should be at least between 400 to 600 for serious MRSA infection. So for exposure dependent, it is the AUC guided monitoring. So do not use one dosing mindset for every antibiotic. Match the infusion strategy to the pharmacodynamic targets. Now, why does loading dose matter? Loading dose is driven mainly by volume of distribution and not by creatinine. So, for your hydrophilic antibiotics, they distribute into the extracellular fluid. And septic shock and capillary leak can dilute the early concentrations. Again, renal dysfunction does not protect the patient from low first dose exposure. So, do not modify the loading dose for your patients with renal dysfunction in the initial phase of treatment. Delaying or reducing the loading dose risks early treatment failure. So, these are the important aspects and why loading dose is essential for patients who are critically ill. Now, common PK/PD targets for the PK/PD targets for the commonly used antibiotics. We just talked about that beta lactams should be the time should be more than the MIC. For aminoglycosides, Cmax over MIC should be at least 8 to 10. For vancomycin, AUC 24 over MIC should be at least 400 to 600. And then for fluoroquinolones and linezolid as well, it is the area under the curve over MIC. Then, just in brief, we are going to have a full lecture on the surviving sepsis campaign 2026. They recommend you collect blood cultures as soon as possible, ideally before antimicrobials without delaying therapy. Septic shock and probable or definite sepsis without shock. Antimicrobials ideally within 1 hour of regulation. And patients with possible sepsis without shock, of course, time limited rapid investigations, but treat it within 3 hours if the concern still persists about sepsis. So, after understanding the basics of antibiotics and the basic pharmacokinetics and dynamic targets, how should your initial prescription look like? You should know what drug you want to select and the indication you're prescribing that antibiotic for. then loading dose, usually full dose for severe infection, even in a patient who has acute kidney injury or on continuous renal replacement therapy. You should have an infusion plan in place, whether you're going to give a bolus, extended, or a continuous infusion. Maintenance plan would depend upon the renal function and the status, whether augmented renal clearance, CRRT effluent rate, patient is obese, and MIC, and then monitoring plan, and you review at 24 to 48 hours. For couple of days, what can she have? So let's look at each of these antibiotic classes individually. Now, beta-lactams. Why infusion in beta-lactams, that is the extended or continuous infusion, important? Because it keeps free concentration above MIC for a larger fraction of dosing interval. And it requires a loading dose first to rapidly reach the target.
No, don't give.
So how would you prescribe a beta-lactam? You would give a loading dose quickly over the first 30 to 60 minutes. Then you decide whether you want to give extended or continuous infusion. You maintain maximal dose if the infection is severe, high MIC, or risk of augmented renal clearance. You check the renal trend. If the patient is on CRRT, the flows, stability, and compatibility, and adjust the dose accordingly. If therapeutic drug monitoring is available, you go ahead with the therapeutic drug monitoring. What are the drawbacks of prolonged infusion that you prescribe for your patients with beta-lactams? Drug stability. Now, meropenem and some beta-lactams degrade with time and temperature, because usually the Indian room temperatures exceed beyond 25 degrees. Prolonged infusion occupies the lumen, so it limits co-infusion of other drugs. And of course, there's a monitoring burden because continuous infusion requires therapeutic drug monitoring, which is not available very readily everywhere. And of course, there is a risk of developing resistance because of subtherapeutic gaps, and it does increase the nursing workload to an extent. So, why is the stability barrier essential, specifically in regards to the Indian ICUs and wards? Because most of the stability data define that room temperature around 25 degrees Celsius is what normally the Indian wards and ICUs exceed. So if continuous infusion stability is uncertain, then extended infusion over 3 to 4 hours may be a safer operational compromise. So, generally this is what is widely practiced. This is what even we do in our ICUs, that you give an extended infusion for 3 to 4 hours. Now, this use of extended or continuous infusions for beta-lactams and the concept of continuous infusion in cases of beta-lactams came into practice and has been very widely used after these two important studies. So one of them was this is a very old study actually, the DALI study, which was published in 2014, which showed wide beta-lactam concentration variability in critically ill patients across multiple ICUs. And as you can see, that only 16% reached the target dosing. Another important study, which was the Link 3 study, which was recently published in JAMA in 2024, which was done basically on continuous versus intermittent piperacillin tazobactam or meropenem in ICU sepsis. Although this was a negative study, but because there was no benefit in the 90-day mortality, but clinical cure was higher with continuous infusion in reported secondary outcomes. Another meta-analysis which was published just after in 2024 was that prolonged infusion was associated with lower 90-day mortality versus intermittent infusion in pooled analysis. So use a prolonged infusion for maintenance, but never skip the loading dose. Again, this has been re-emphasized in the Surviving Sepsis Campaign 2026, that prolonged beta-lactam infusion for maintenance after the initial loading dose. So what would your beta-lactam strategy be? You have a patient with severe infection, you give full initial loading dose regardless of the renal status of the patient, assess the pharmacokinetic risk, look at the possibility of the augmented renal clearance, AKI, obesity, patient with hypoalbuminemia. Then subsequently decide what infusion you want to plan, extended or continuous maintenance for your patient. Monitor based on the clinical response, renal trend, toxicity and therapeutic drug monitoring wherever available. Adjust and de-escalate based on the response. And always remember, you need to source control. We've talked about this enough. Every time you're treating a patient with infection, just by randomly treating the cultures and with antibiotics is not enough. You always have to achieve source control for the patients who have a specific source of infection. Then in ICU, every antibiotic prescription should identify the patient's current phenotype. So there are 4 basic ICU dosing phenotypes. Of course, a patient with normal clearance, standard dosing may be adequate. But then there is augmented renal clearance, which is the first phenotype, acute kidney injury, continuous renal replacement therapy, and obesity. So what is augmented renal clearance? The first phenotype, which usually means measured creatinine clearance of more than 130 ml per minute per 1.73 meters square. It's common in patients who are younger, trauma, those with high cardiac output. So your serum creatinine it may look absolutely fine, but your beta-lactam troughs will be subtherapeutic. So what would this result in? It would result in treatment failure, developing more and more resistance, and it would ultimately increase your patient's ICU stay. So detection requires measured urine creatinine clearance. So basically, what is the basic pathophysiology? You have patients in sepsis, trauma, burns. So there is a lot of inflammatory process that is ongoing. It's in hyperdynamic state. Patients are vasodilated, high cardiac output, renal blood flow increases. You are giving fluids, pressors. There is augmented perfusion. So the GFR will increase. So measured creatinine clearance would increase, which would ultimately result in decreased exposure. So time above MIC would fall. So do not prescribe only the antibiotic name. Prescribe the dose, the infusion time, the renal plan, as well as plan monitoring simultaneously. So again, just to summarize the ARC dosing algorithm, you have a patient wherein you have the risk factors and you're suspecting augmented renal clearance. Measure the creatinine clearance at 8, 12, 24 hours urine creatinine clearance. Give full loading dose and optimize infusion. Then you reassess daily because augmented renal clearance may resolve as the illness gets better. Wherever therapeutic drug monitoring is available, you can use that as well. Use high-end dose, especially if there's high MIC or deep infection. Now, the second phenotype is the AKI. Now, early sepsis AKI does not mean that the loading dose should be reduced. So, loading dose should usually be preserved because volume of distribution is increased and infection is life-threatening. And maintenance dose depends on the renal trajectory, whether the patient is improving, stable, the renal functions worsening, has the patient become anuric now or has gone on renal replacement therapy. This is very important. So for the common antibiotics that we use, what should be your approach? For beta-lactams, give full dose. I'm talking about AKI. So in AKI, for beta-lactams, give a full loading dose and prolonged infusion. Adjust maintenance after reassessment. Vancomycin loading dose if severe, and then you do an early AUC over MIC or therapeutic drug monitoring and renal assessment. For aminoglycosides, use only if there is a strong indication and full loading dose if needed. For linezolid, again standard initial dose, you need to only monitor for thrombocytopenia, that too on prolonged therapy. Colicin and polymyxins are generally preserved these days. It is recommended to use polymyxin sparing strategies. Then the third phenotype is the continuous renal replacement therapy. So drug removal would depend upon the effluent rate, the modality, membrane, protein binding, sieving or saturation coefficient, and interruptions. And loading dose is generally not reduced. Maintenance dose is individualized to CRRT intensity and therapeutic drug monitoring. So there are various CRRT modalities that we use. We all know about these modalities, but remember when you're calculating your dose for a patient who's on CRRT, a practical approach is that you look at the residual urine output, the total effluent rate, filter life, the drug that you're choosing, what is the protein binding, then infection severity, how sick is your patient. The MIC, and of course therapeutic drug monitoring wherever it's available should be used along with it to decide about the dose of your antibiotic. So in continuous renal replacement therapy, practical dosing plan is that you do not write the renal dose. You write a CRRT plan, which is giving a full loading dose for severe infection, regardless of the CRRT start. Set maintenance dose by the modality that you're using, total effluent rate, residual urine output, and infection severity, like I just told you, and then reassess. This is something that sometimes it is forgotten. You need to reassess if you've changed the filter, if there has been a CRRT interruption, if there's been a change in the effluent rate or return of urine output, because these again change the plan for your dosing of your antibiotics. Then the next phenotype is the obesity. Now in obesity, there is increased adipose and lean mass, sometimes even cardiac output and renal clearance. So hydrophilic drugs may have modest volume of distribution increase, and lipophilic drugs are affected differently. So you should, weight scalar in these patients differs by drug. So whether it is total, ideal, adjusted, or lean body weight, and you should use therapeutic drug monitoring when available. So of course these are the ideal body weight and adjusted body weight are the methods by which you calculate the body weight. Adjusted body weight is useful for aminoglycosides for initial dosing in obesity, and of course we know about the total body weight. So when we look at the common antibiotics that we prescribe and how does obesity have a role, especially in deciding upon the dose? So again, for vancomycin, loading is often based on the actual body weight. For aminoglycosides, adjusted body weight is what is commonly used. For beta lactams, often standard or high-end dosing. And you optimize infusion. Daptomycin is based on the actual or adjusted body weight. And for again fluoroquinolones, high-end dosing if there is severe infections. Then there is another aspect which is not always thought of in the first instance. You may have an obese patient along with who's having augmented renal clearance. So an obese septic patient may have an increased volume of distribution and increased creatinine clearance simultaneously. Again, use prolonged infusion and high-end maintenance until cultures, MIC, and you've measured the clearance. So the next phenotype is the hypoalbuminemia. It's actually more of a state than just being a phenotype, because there are patients who would have low albumin states. So when the albumin is low, it would increase the unbound fraction of highly protein-bound drugs. So the total drug concentration may look low while free concentration is quite high. And in critical illness, it may also increase clearance of the free drug. So unbound therapeutic drug monitoring is ideal for such selected drugs wherever it's available. And in brief about therapeutic drug monitoring, so position paper recommend routine therapeutic drug monitoring in critically ill patients. Surviving sepsis campaign suggests antimicrobial therapeutic drug monitoring on case-by-case based on clinical features, pathogen or resistance, drug class, and availability. And if you are actually using therapeutic drug monitoring, then it should trigger an action, not just do the TDM levels. You should see whether you need to actually increase your dosing, decrease, change the infusion, maybe repeat the level, or de-escalate your antibiotic. Then we've just talked about it. So just to summarize again, for vancomycin, the target is AUC 24 over MIC should be at least 400 to 600 for serious MRSA infections. Aminoglycosides peak over MIC of at least 8 to 10. Beta lactams, time over MIC. Voriconazole, therapeutic trough levels as per the local lab. And for linezolid as well, AUC over MIC. So let's understand whatever we've just heard on simple case. Let's look at a few simple cases. So there's a patient of pneumonia in shock with a creatinine of 1.2, high lactates. You resuscitated with 3 liters of fluid. So now there is a risk of increased volume of distribution, which would result in low dosing of hydrophilic underexposure of the hydrophilic beta-lactam antibiotics. So this is what is important, and this is what I've been trying to tell you, that you need to remember this thing and keep this in mind, and not just write, if for example meropenem 1 gram IV 8 hourly, you need to, and once you've prescribed, you need to reassess your doses at 24 hours based on the culture, the renal trend, and of course the response to treatment. Then another case, patient of urosepsis with a creatinine of 3, oligouric, hypotensive, even after resuscitation. So do not reduce the initial beta-lactam dose, loading dose in life-threatening infections like this. That is what is the message from this case. Then a patient on continuous renal replacement therapy presented in septic shock, AKI, started on renal replacement therapy, and meropenem was continued at renal dose. So again, when you are putting your patient on renal replacement therapy, you need to keep in mind that what mode in effluent rate and downtime, you need to check these, and loading dose remains the same. You have to give a full loading dose. And maintenance dose often needs higher dosing than the traditional renal dose. Then a patient with a BMI of 42 developed a ventilator-associated pneumonia. Renal function was apparently normal and had a pseudomonas risk. It was suspected that he has a pseudomonas infection. So you use high and beta-lactam dosing in these patients. Prolonged infusion, like I just told you about the dosing in obese patients. For vancomycin, loading dose often uses actual body weight, but you need AUC monitoring. And for aminoglycosides, adjusted body weight is what is used for prescribing the antibiotic. So, just to summarize the bedside algorithm for prescribing antibiotics, you decide first, you look at the severity of infection, you look at the source, and you start achieving source controls simultaneously while you start your patient on antibiotics. Give the loading dose irrespective of the renal function or the initial renal status of the patient. Identify the PK phenotype. Choose your infusion strategy properly. Monitor intelligently and reassess daily. ICU antimicrobial prescribing is a dynamic precision dosing, not a static renal table. So common mistakes that we make, we reduce the initial loading dose because creatinine is high. You use normal creatinine as proof of normal renal clearance in patients who have augmented renal clearance. You run prolonged infusions without an initial loading dose, ignoring the renal replacement therapy interruptions, flow changes, and bitter clotting, using actual body weight for every drug in patients who are obese, continuing nephrotoxic combinations after cultures are showing you that you can de-escalate or stop, and not recording infusion and sample times for therapeutic drug monitoring. So I think I've talked enough about the loading dose and I've loaded enough. So I hope that everybody is going to remember that you do not, not give loading dose to your patient. Full loading dose is recommended, and you personalize the maintenance dose. For patients in sepsis and septic shock, prolonged beta-lactam maintenance after the loading dose is now guideline supported. And ARC causes underdosing. Do not forget the probability of that, and remember the phenotypes while prescribing the antibiotics like AKI, CRRT, and obesity. And therapeutic drug monitoring, wherever is available, should be used appropriately. Thank you.
Thank you very much, Dr. Aakanksha, for that excellent overview of the previous module on PKPD and antimicrobial dosing in antimicrobial dosing in the ICU.
So, thank you, Dr. Aakanksha. And so, I have a great pleasure in introducing moderator for the today's session, Dr. Sheila Myatra. She is well-known person in the critical cares and the anesthesia circles, and she is currently the professor of critical care medicine at Dhaka Memorial Hospital, Mumbai. She is past president of Indian Society of Critical Care Medicine. She is the first lady and the only lady who's become the president of Indian Society of Critical Care Medicine. Very dynamic person, She's been chair of Intensive and Critical Care Medicine Committee, past president All India Difficult Airway Association. She's the main person who has been instrumental in making the guidelines for difficult airways. And it is a pleasure that the person who was part of the Surviving Sepsis Campaign 2026 is moderating this session. Dr. Sheila Myatra was part of the Surviving Sepsis Guideline Committee. She's also part of the steering committee Asia Pacific Sepsis Alliance, contributor of ESICM guidelines on circulatory shock. She's the pioneer in the original research on tidal volume challenge, which many of you are aware of this. She's very high HITEX 63. She's published widely many papers, more than 200 or 300 papers. And she's got the ESIC honorary membership, EAMS honorary membership, and still going on. She's all over the world for lectures. So hand over to Dr. Sheila for conducting the proceeding. Dr. Sheila.
Yes, thank you very much, Dr. Chawla, for that very kind introduction. And now I have the honor and pleasure of introducing Dr. Rajesh. And he really needs no introduction, and he's been chairing this session, an excellent academic section with ongoing sessions every week. So Dr. Chawla is a senior consultant in the Department of Respiratory Medicine and Critical Care and Sleep Medicine at the Apollo Hospital, Indraprastha Hospital in New Delhi. And he has several academic achievements and accolades, professional positions and roles that he's held. He's been Chancellor of the Indian College of Critical Care Medicine. He's been the past president of the ISCCM. He's been president of the National College of Chest Physicians, vice chancellor of the Indian College of Critical Care Medicine. And he's also received several honors and recognition. Very recently, he was one of the first MICCM awardee, that is a master of the Indian College of Critical Care Medicine, that has just been started in 2026. He's also got the R. Vishwanath Oration at NAPCON in 2021. Presidential citation from the Society of Critical Care Medicine in 2010 and 2011. Several global engagements, National Indian Society of Critical Care Medicine, National College of Chest Physicians, and also for the Association of Physicians and Delhi Medical Association. Internationally also at SCCM, European Society of Intensive Care Medicine, and also the American College of Chest Physicians. His research highlights are he's been principal investigator of multiple ICU and COVID-19 trials, international INEC studies, also looking at nosocomial infections, and he's also been a contributor to national and international guidelines. Several publications to his credits, and he's also authored and also edited several books, and the most popular one among the students, of course, is the ICU Protocol book, and the third edition has been out in 2025. And Dr. Chawla is very well known for organizing excellent conferences, and his area of interest is, of course, critical care medicine, but ventilation, ARDS, NIV, sepsis in ICU, and infections, and of course, pulmonary and sleep medicine. And without any delay, I asked Dr. Chawla to he'll be speaking to us for the next 30 minutes on early recognition and initial management of sepsis in respiratory and ICU infections. Over to you, Dr. Chawla.
Thank you very much, Dr. Sheila, for nice introduction. And we have a pleasure of working on many projects in ISCCM along with Dr. Divatia. So it is a pleasure to share the stage today with two very good friends. So, I'm going to talk of the sepsis, which I think most of you manage in day to day. And I'm going to tell you that what is the current recommendation for managing sepsis in the early management, and how to manage that. And what are the learning objectives? Is the early recognition of sepsis, brief initial resuscitation, initial investigation bundle, antibiotic down timing, empiric antibiotic selection in Indian ICUs, early reassessment, de-escalation, and duration and stewardship. So this is what I'm going to discuss in the next half an hour. So the message right at the beginning, which I'm going to tell, very loosely we use the word sepsis. Sepsis is not fever plus antibiotics. It's infection with acute organ dysfunction. So if a person has life-threatening organ dysfunction due to infection, then only you call it a sepsis. Antibiotics will save life when sepsis is probable or definite, but harm patients when given reflexively. And first hour is not only the treatment time, it's also the sampling and source utilization. We have always been talking about the antibiotics. And the best empiric antibiotic is source-driven, risk-driven, and antibiogram-driven. So all these things have to be kept in mind and must be reviewed. The antibiotics within 24 to 48 hours, you must review them. So before I go ahead, I think some definitions you must know. When you call infection, it is a microbial invasion of the microorganism causing host response, that is infection. When the infection results in life-threatening organ dysfunction due to dysregulated host response, that's called sepsis. And when the sepsis is severe enough to cause circulatory and metabolic dysfunctions, and it is recognized by when a patient has sepsis-induced hypoperfusion or hypotension, which after fluid is you require vasopressor to maintain blood pressure, and serum lactate is high for septic shock. Now there is always difficulty, certainty is always doubtful. So Surviving Sepsis campaign has come with some terminology which they have used all through the guidelines. So they are called definitive sepsis when you have a patient who has got a confirmed infection based on the history, clinical examination and diagnostic tests, plus has organ dysfunction, and the alternative diagnosis is unlikely. You call it a definite sepsis. Probable sepsis is when you have a high suspicion based on the history, examination and diagnostic tests, infection is most likely. These two are important because in these two conditions, you need to give antibiotics within 1 hour. Possible is the alternative is also possible. So then you should evaluate the patient and give the first dose in 3 hours. Maybe it is not infectious. Unlikely means the clinical picture, the diagnosis, clinical and the history, clinical examination, and the diagnostic test, they favor the non-infectious course. So do not start reflex antibiotics. So this is the reason they have given these different. So first is recognize sepsis early. See, there are a lot of screening tools which have been proposed. And QSOFA we have been using. And now it is recommended that patient on his way to the hospital in an ambulance or in a flight, you should use this screening tool to diagnose sepsis so that you can alert the hospital so the time to antibiotics and other tests is hastened. So QSOFA we have it is insensitive but specific, of course. The SIR is again sensitive but low specificity. Out of this, NEWS2 is the one which is most sensitive and specific. And these tools can also be used if a person develops sepsis inside the hospital to quickly diagnose and then take action on that patient. And this is what the SCC 2026 recommend, that use these new tools over QSOFA as a single hospital screening tool. Now it is also recommended that you should have a code sepsis. We have a code in the various codes in the hospital. So code sepsis is that when a patient comes, you have a multidisciplinary team. The response team, it can be the various constituents can be in a different hospital, but the major is that the treatment is given faster. So what will happen is the leader will confirm, there are 4 to 5 people as a part of the code sepsis team. Leader will confirm the suspicion, he sets a timeline, nurse is doing the vitals, lactate, IV access, and some physician is examining patient at foot to find out what is the source of sepsis, and the microbiology is being sent, and the antibiotic is being decided based on the renal adjustment if they are available. The purpose is all these things is a parallel execution. It is not one after the other. So that is why every hospital should have a sepsis, code sepsis, so that the time to first antibiotic, the test, imaging are done faster, so that we have a better survival in these patients. So early management priorities in sepsis is recognize. Sepsis should be recognized early. Classify the patient into possible, probable, or definitive sepsis. Take the samples, blood plus the site wherever the source is. Timed empiric antibiotic 1 hour or 3 times. And then if there is source, train, remove, or operate. So this is an early management priority. They should be taken care of in a patient, and these are again parallel. Quickly you do all these. These are when you have a patient of sepsis. And one of the most important thing when you're doing this, resuscitation also runs in well. Some of these patients come very sick. So when the history examination cultures are underway, you should stabilize the patient. We know that ABC, the patient, whether he can protect airways, that's a very important thing. Whether he's in distress, give him oxygen, take an ABG sample. If there is a lot of work of breathing, you give a HFNSC or NIV. And if patient can't protect airways, or you feel that he's too distressed to be put on non-invasive modalities, he should be intubated. Similarly, circulation plays two good peripheral IV lines, and the cultures and sample can be taken out of that. And if patient is hypotensive, start in these patients 30 ml per kg. That's what the SSC has suggested. But beware, if a patient, many of these patients who land in sepsis, they have CKD, heart failure. So you give fluids, reassess. Every 15 to 30 minutes, you should see blood pressure, mean arterial blood pressure, pulse pressure, capillary mentation, urine output. And nowadays in a modern ICU, most of the tertiary care center, you have a bedside lung ultrasound. You can see the lung, the IVC, cardiac ultrasound to detect the fluid tolerance and cardiac limitations. So one bolus or one lactate does not repeat. You have to, till the patient gets stabilized, you have to reassess these patients. Now 1 hour versus 3 hours. So 1 hour you should give antibiotics if there is a probable or definitive sepsis. Sepsis with hypotension or organ hypoperfusion. Patient is very sick with meningitis, necrotizing soft tissue infection, severe pneumonia, febrile neutropenia, high-risk immunocompromised. This is within 1 hour. If it is possible sepsis without shock, then you should give within 3 hours. This is actually based on the study which was published by Dr. Anand Kumar way back in 2006, where he showed the delay in antibiotic increases mortality. Then there was a paper by Seymour in NEJM in 2000. But there is that early appropriate antimicrobials are associated with improved survival in sepsis cohort. So we should try that we should give antibiotic as early as possible and within 1 hour in definitive and probable sepsis. Now, what are the initial investigations we send when patient is there? So, investigations should answer 4 questions. Is there acute organ dysfunction, which will help you to make a diagnosis of sepsis? What is the infection source? Which pathogen is likely? Which empiric antibiotic is adequate but not excessive? What data will allow de-escalation at 24 to 41? So all your investigations should answer this. So first is the minimum biochem initial lab panel. You do an inflammation for CBC, differential and platelet, because you want to see neutropenia, thrombocytopenia. Organ dysfunction, which are also the SOFA elements, creatinine, urea, LFT, bilirubin, and coagulation. Then for perfusion, ABG and lactate. Remember this blood lactate, which we do in these patients. It's a marker of stress physiology, possible impaired perfusion. It does not mean it is not infection or source specific. Measure it early and then you repeat it to see whether it is improving. Always remember that in Caesar, beta agonist patient, liver dysfunction patient with severe hypoxemia and severe anemia, high lactate can be there without even hypoperfusion. And always remember the improving lactate. If you give fluid, you give treatment, the lactate is improving does not mean the patient is improving. It just means that there is improving perfusion. Then the others are CRP and PCT. These are not used to rule in or rule out the diagnosis. They are mainly for trend or de-escalation. So one can get it done initially, CRP or PCT, which will tell them it will, even if it is low, that does not mean in definitive or probable sepsis, you will not start the treatment. For the safety, renal and hepatic baseline should be. So these are the minimal biochemistry you should do. Blood culture is very, very important. And you should give a lot of importance to this. More antibiotics. Under asepsis, two sent from separate site at the same time. There is no need of a gap between first and second sample. You can take from two arms, preferably peripheral venipuncture. If a patient has a catheter-associated infection, is a nosocomial infection, then you should take one peripheral sample, one central line sample, and from at least two ports, and send at least 10 ml of blood. Do not wait for fever spike. Somebody may say, when the fever comes, take culture. No, just take the culture. And documents whether patient has already received antibiotics or not. Because if the culture comes negative, it explains that. Then the other sample microbiology said is site-specific culture. Do not culture everything. You know, when a patient gets a fever in the ICU, you just either escalate antibiotics or send all the cultures. Examine the patient and then send the culture, which will give you the diagnosis. So urine culture only when you are thinking urine is the source. If a patient has a catheter and you think of catheter-associated infection, then do not send the sample from the catheter. Asymptomatic bacilluria is very common in a patient catheter. So change the catheter, and from the new catheter, you send the sample. Respiratory sample when pneumonia is clinically suspected. Avoid superficial wound swabs and cold drain cultures because they are always colonized. So, and positive culture without a syndrome, if patient has no symptoms, but you are getting culture, that does not mean anything. This is just a colonization. Then imaging. Imaging in these patients, chest X-ray or lung ultrasound when respiratory source is suspected. Bedside ultrasound is very useful modality for pleural fluid, even for abdomen, hydronephrosis, cholecystitis. When you are not sure of the source of sepsis, you should do a CT chest, abdomen, pelvis. And when you are suspecting endocarditis, like embolic phenomena, any embolic phenomena in these patients with sepsis, echocardiography, and many a time we do a transesophageal echo also. Now, biomarkers, I have already talked about this. No biomarker will rule in or rule out. High probability infection, do not use low normal to withhold antibiotics. They are useful in low to intermediate probability as an adjunct. Maybe you can stop the antibiotic if they come negative. Now, there are a lot of new post-response tests have come in the international market. MDW, DeliSep, Septicide, the SSC 2026 found insufficient evidence to recommend routine use of this novel host response test. Now, the other test which we do is a rapid pathogen test. You know, there are a lot of tests available. You should not have a knee-jerk send a rapid respiratory panel, the pneumonia panel. If there is a clinical syndrome, if person has a sign of pneumonia, send the pneumonia panel. Similarly, respiratory influenza respiratory panel if you're suspecting influenza or viral infection. Or if there is a meningitis or encephalitis, send the CSF panel. It detects the genetic material. It does not prove viable infection or susceptibility. Always send the cultures. Conventional culture must be sent. This is just to start the antibiotics if you get an answer little early before the cultures. And they must be feed into the stewardship. Escalation is escalation or stopping. You know, these are the common sources, respiratory, urine, and line you should look. Similarly, for abdomen and skin and CNS, all of you are aware of these causes which can result in sepsis. So, for source localization, the first is the history, recent procedure. These are very important things. Any travel or devices to these, and then examine the head to foot. This is what is not done. If you are standing at the bedside at the foot end of the patient, that is not proper. You must undress, put the curtains, ask an assistant, and do a head. It takes 2 minutes. In the head, you examine the sinus, orodental hygiene, remove the dressings, look at the central line, neck side. The patient is intubated. Ask the sister, how much are the secretion? Are they yellowish? Is the amount increased? Then auscultate the chest. If there is a new sign, if you've been auscultating, you'll be able to pick up. In the heart, if there is any new murmur has appeared, in new onset fever in ICU, if you find a new murmur, it's an indication probably there is endocarditis. Similarly, abdomen, look for drains. Is there any increase in the drains? Wound in the abdomen. Then similarly for the perineal area, the limb you should look for the cellulitis, necrosis, and DVT. You know, I have detected at least 20 to 30 DVT I can in my career by just undressing when we were not finding the cause of a low-grade fever. DVT is missed if you do not examine it. So the source is often found by removing dressings, inspecting lines, looking under the patient and examining drains, not by another broad-spectrum antibiotic. Then based on your source, you send the cultures, send the imaging, and then source control, drain, remove, operate. So that is how you manage these patients. Now, the most important part is the antibiotics. So you should have a right patient, give a right drug in a right dose, loading plus PD strategy as you just heard, for right duration and right source control. So these are the antibiotic goals in early sepsis. So before the first dose, 5 rapid checks. Source, what is the source? Lung, urinary, abdomen. What is the severity? Is there a lactate is high, organ dysfunction, oxygen? Is the PF ratio has increased if patient is on a ventilator or a support? BP, mentation. This will tell us the severity. Then host, is immunocompetent or immunocompromised? Neutropenic transplant. Then exposure. Has he been exposed to antibiotic? Is he in the hospital? Has he got devices? Is there a colonization we know? So that's a 4th. And safety, how are the renal and hepatic function? So these 5 things you have to keep in mind when you select an antibiotic, because if you have to select, you have to keep it renal and hepatic safety as well when you select. Then, of course, we have talked about 1 hour and 3 hours. Then selection of empiric antibiotic based on the source. If it's a pneumonia, if it's a community acquired, you know what you have to cover: strep pneumonia, H. influenzae, Moxella, or atypical organism. And MRSA and Pseudomonas, is there a risk of them in a community acquired as well as in HAP or BAP? Urinary, gram-negative, abdomen, gram-negative for anaerobes, Enterococcus, Candida, if there is a risk. Skin and soft tissue, you have to cover Streptococcus and Staphylococcus. For Lyme, Staphylococcus. Gram-negative, if a patient is unstable, neutropenic, then you have to cover the gram-negative also. When to broaden and when to narrow initially. Broaden the initial coverage for shock, MDRS, and immunocompromise. And give a narrow when it is a community-acquired infection with low MDRS and patient is stable. So these are the 2 important things which you should keep in mind when you cover the patient with antibiotics. Do not start antifungal in every septic who is not responding in 2 days. So consider in a high-risk patient with recent abdominal surgery, perforation, TPN, immunocompromised, multiple Candida colonization, prolonged broad antibiotic, immunosuppression, on dialysis. So these are the risk factors when you should consider that patient may have fungal infection if he is not responding. And then, as we have discussed, that we should give a full loading dose and we should give all beta-lactam as a prolonged or continuous infusion strategy, as has been also recommended by the SSC 2026. So this is the beta-lactam dosing workflow you just heard. Load dose fully, maintenance extended or continuous based on the PKPD, adjust based on the renal, ARC, CRRT or ECMO, and then review after the culture, MIC or TDM if available to you. Therapeutic drug monitoring should be considered when you are giving vancomycin, aminoglycoside, some of the beta-lactams and azoles. And it is only useful if the result will change the next dose. Just getting a TDM and not acting on it is also not good. Then do not postpone the source control, because once you have an abscess, it should be drained as early as possible. And PIMA, you should put a tube right at the night. Remove infected devices. Debride the necrotizing tissue. You see, it is not 24 hours. It it is emergency for an intensivist all the time. They should be ready. If you can't get up at night, you can't be intensivist. So all these things should be done at night. Source control should be assessed in parallel with the antibiotics, not after antibiotic failure. And you should review all antibiotics, whatever you do, at 24 to 48 hours. Because you should try to de-escalate, because the major problem is that patient gets better and we won't de-escalate. When we isolated strep pneumonia, we'll still continue with garment. Please don't do it. You should try to narrow down once you culture, especially blood culture or a sterile site culture. You must de-escalate, because you are not there to make your patient well, but you should not create resistant bacteria for others to get unwell. And de-escalation, I have already talked about. Then duration. The shorter course is often enough for pneumonia, for UTI, controlled intra-abdominal source, uncomplicated gram-negative bacteria, and biomarkers can also help in stopping the antibiotics. We should not continue antibiotics just because patient is on a ventilator. 7 to 10 days, most of the infections are better. You must stop. And if there is a pneumonia, 7 days are enough. In abdominal infection, most of the surgeons, they stop after 5 to 6 days. Longer is also required for Staph aureus bacteria, endocarditis, CNS infection, osteomyelitis, uncontrolled source, abscess not drained or can't be drained, severe immunosuppression. There you need a longer. So you must stop when it is required for a shorter time. So when you're writing a prescription, minimum feel you should, when you write in your file, always start writing like this. Write down what is the indication. So there is a probable HP with acute hypoxemic respiratory failure. This is an example. Culture sent blood, culture 2 sets, and ETA culture for because your ICU is growing, so at least pulmonal coverage was started. Because the patient has been staying, and so it must be a hospital required. Those strategy, loading dose given, extended infusion and maintenance is planned. Write down how you want to give it. And then review cultures, PCT. So that's the order you should write in prescription. So the next person who sees, who knows what to be seen when he comes on duty. So I'll just show in the end about 4 or 5 cases. 75-year-old, 2 days history of fever, tachypnea, new infiltrate. There is a rise of creatinine, lactate is 3.2. So what is that? So the patient has a probable sepsis, and it is a respiratory source because there is a new infiltrate, fever, tachypnea. So immediate action is you send the blood cultures, sputum if possible, lactate plus renal and liver panel, chest X-ray, ultrasound. Antibiotics start within 1 hour because of probable sepsis. And you will cover for others, MRSA or Pseudomonas if there is a risk. And then you review at 48 hours. So, in probable pneumonia, probable sepsis, the treatment should be started in 1 hour, but it should be reviewed at 48 hours. So, this is a patient, 65-year-old, post-abdominal surgery. Temperature is 38.5, WBC 15,000, BP is stable, lactate is 1.2. So, what is it? You're not sure. It is just 1 day post-abdominal surgery. So it could be possible sepsis. It could be just a post-operative inflammation. So what will you do? You will do a focused wound and drain examination. You send the culture if you're really concerned. And if there are signs, then you do an ultrasound or CT. Then you use a 3-hour. You get all these ultrasound or maybe CT. And then there is no reflex broad antibiotic if no source and patient is stable. So if BP is stable, patient is not that tachycardias. Give it 3 hours, maybe that patient is not requiring that. Then review point is suppose next day there is a leak, abscess or peritonitis appears, then you escalate the treatment. So that's how you manage it. So there's another fever, rigor during infusion, central line in place, hypotensive, no obvious alternate source. So it could be a probable catheter-related bloodstream infection. So it's a probable sepsis. So what we'll do immediately, peripheral and catheter cultures, inspect, insertion, and check other sources also. And if you find this is the source, then cover staphylococci, and if there is a risk for gram-negative, as I discussed, you add, and then review is that you remove the line and then particularly if it is a tunnel infection, Staph aureus, Candida, persistent bacteremia, you must remove the line. Then case 4, recent surgery procedure, again, but there is an abdominal distension after 2 days. There is a tendernal rising lactate, tachypnea and PF less than 200. Now this patient is not inflammation. This is a probable source control sepsis. So there's something has appeared in the abdomen. So you send the blood culture, urgent CT ultrasound, ask the surgeon to look at Havicol, cover gram-negative, anaerobes, and add enterococcus if there is a risk, and fungal if there is a risk in this patient, and then review point is drain, repair, debride, and do not treat as unknown sepsis for 48 hours. Always look for the cause of sepsis in every patient. So what not to do? Do not give broad antibiotics to every fever without source or organ dysfunction. Do not wait for all report when sepsis is probable and the patient is deteriorating. Do not culture old drains, superficial wound, or colonize tube and treat the report alone. Do not forget the source control. Do not continue just in case antibiotics after infection becomes unlikely. Just in case, do not give it because we have already created a lot of MDR in our country. So putting it all together, I've already talked, suspect, classify, sample, treat, and reassess. So just to conclude, so recognize sepsis as infection with acute organ dysfunction, not just fever.
Very light.
If there is no acute organ dysfunction, it is just infection. Classify properly.
Very light.
Possible,
That you can
probable,
control by your
probable.
diet and all.
This sets the 1 hour versus 3 hour antibiotic clock. Sample correctly before
No
antibiotics
sugar
when feasible. Blood culture, site culture, lactate, lab, and source targeted imaging. Treat with source-driven, severity-driven, and antibiogram.
Here, thyroid also, it is absolutely
with correct loading dose and do not give, let us cover this, let us cover this like that. Reassess at 24 to 48 hours. Source control, culture results, de-escalation, stopping disease and plant.
Okay.
So early sepsis care is a fast classification.
No oily, spicy,
correct
no non-veg and all for some
adequate
time.
Antibiotics, source
Drink more
control,
water, do
and
little
discipline
walk.
the assessment. Thank you very
More than
much.
enough.
Thank you very much, Dr. Chawla, for an excellent overview of the early recognition and initial management of sepsis. And the cases were really excellent, through which you were able to give us examples and demonstrate what you were telling us about. So now we move ahead with another doyen in the field of critical care medicine, who's going to take the second talk, which is going to be the management of septic shock in the intensive care unit. And we have none other than Dr. Divatia, who will be taking this talk. He again needs no introduction, but if I can have the CV on, I can just give you a little overview of his profile, which is very long, of course, but if we can have Dr. Divatia's CV on.
Oh, it is there. You can't see?
Yes. So Dr. Divatia is the head of critical care medicine at the Lilavati Hospital and Research Center in Mumbai, and he has several academic achievements and accolades. He's been senior intensivist with almost 35 years of experience. He's former professor and head at the Tata Memorial Hospital. Most of you still think he may be at Tata. He's just recently joined Lilavati Hospital, and he has trained in intensive care at the St. George's Hospital in Sydney. He's been past president of the Indian Society of Critical Care Medicine, also the Indian Society of Anesthesiologists, and also the All India Difficult Airway Association, several more than 200 plus publications and high H-index too. And his areas of interest are sepsis, mechanical ventilation, hemodynamic monitoring, airway management, critical care research, and education. So Dr. Divatia will be talking to us about the management of septic shock in the intensive care unit. Over to you, Dr. Divatia. We'll take questions at the end of both the presentations. So keep your questions going on in the chat, and we'll have both the speakers taking these questions. Thank you.
Good evening, and thank you for that kind introduction, Dr. Sheila, and thank Dr. Chawla, Rajesh Chawla and Aakanksha Chawla both for having me speak here at this very wonderful initiative that is going on, the education in respiratory and critical care medicine, and I'm happy to be part of this. I hope you can see my slides, and I hope you can hear me clearly.
Yes, sir.
So Dr. Chawla has taken you through the initial management of sepsis as far as the antibiotic therapy is concerned, and I will speak to you more on septic shock and largely the hemodynamic and the management. Now we already know what is sepsis, and we also know what is septic shock. And septic shock, is sepsis with persistent hypotension requiring vasopressors and having a lactate more than 2 despite adequate volume resuscitation, which we've heard. Okay. Now, whether you've got probable sepsis, definite sepsis, what we really need to understand is that sepsis and septic shock are both medical emergencies and both need to be treated with great urgency. When we talk of, sepsis results in multi-organ failure, multi-organ dysfunction. When we talk of, say, myocardial infarction or we talk of stroke, we have a window, right? That within X minutes you need to reperfuse the heart or you need to reperfuse the brain, and time is tissue for us, isn't it? So if you're delayed, then you cannot save the remaining brain, you cannot save the heart. So in the same way, sepsis and septic shock affect the whole body, therefore they cause global inflammation throughout the body, and therefore, again, we need to treat it as an emergency and act in a very time-bound manner as far as certain issues are concerned, because again, time is tissue, and here it's not just one organ you're going to be dealing with, you're going to be dealing with multiple organs, many of which are likely to fail if you don't get that treatment right. So the management of sepsis, is sort of in 3 parts. So one is the control of infection, which Dr. Chawla has very elegantly dealt with. And I will focus on restoring organ perfusion because remember, septic shock, you've got organ hypoperfusion and you've got metabolic derangements with an increase in the lactate levels, and you've got organ dysfunction as well. And maybe, as we define sepsis as a dysregulated host response to infection, maybe we can try and modulate the host response. I will not spend much time on modulating the host response because by and large, even though we are in 2026 June, we've not had much success with modulating the host response, so we think we can try. And I'll focus largely on how we can restore organ perfusion and control the infection is the other key component that we need to deal with, right? And again, almost everything I'm going to say, I'm going to take you to the new guidelines which have just been published on the management of sepsis and septic shock. These are the surviving sepsis campaign guidelines. Okay. So we need to begin treatment immediately. And once you identify sepsis-induced hypoperfusion or septic shock, then you must give an initial fluid bolus. And the recommendation is to give 30 mils per kilo of IV crystalloid within 3 hours. So start immediately and finish it within 3 hours. Now, when we are going through the guidelines, and I'm going to take you through them, if there are 2 green ticks, then it's a strong recommendation. So it's a recommendation to do it. And when there is 1 green tick, right, it means that there is a suggestion. In other words, it should be done provided there's a fine print. And in these guidelines, they are extremely evidence-based. So unless there's strong evidence, unless there's good evidence, a recommendation is not made. But they've also got what they call as remarks. In other words, the fine print. And I think it is extremely important that we also understand the fine print, because the broad recommendation, as it is over here, is made, on the overall evidence, whether it may be very strong or maybe moderately strong or weak. But this line, this giving 30 mils per kilo of IV crystalloid within 3 hours is carried over from the previous guidelines, which are 5 years ago. And this was criticized and many people did not like it because this means for a 70 kilo person, you're going to give a 2 liter bolus over 3 hours. And people often argued that, well, what if this patient has heart failure? What if this patient has got chronic renal failure and he's got pulmonary edema and sepsis, And these are common cases that come up. What if it's a 80-year-old with a community-acquired pneumonia who also has an ejection fraction of 20% or 25%? So now, what has actually happened is that almost this recommendation is based on observational data of many, many, many very good randomized controlled trials, which we're not looking at 30 mils per kilo or less or more. We're looking at other aspects of management of sepsis. But in all these studies, almost all the patients prior to randomization had received approximately 30 mils per kilo or sometimes even more. So in other words, it seems to be that this was the sort of standard which people were following even in randomized controlled trials, and therefore they've stuck to this recommendation, right, to give 30 mils per kilo. So that means for an average Indian male who weighs about 60 to 70 kilos, they're going to give roughly 2 liters of fluid. For an average Indian female who weighs about 50 to 60 kilos, they're going to give about 1.5 liters of fluid, right, in the first 3 hours. Now, but there is a fine print that they also publish, okay, and they also write that consideration should be given to individual patient characteristics. So, for example, you should perform frequent assessment. So, you're going to give, the plan is to give 2 liters of fluid over 3 hours, but after 500 ml or after 1 liter, you can always reassess the patient, right? And you can reassess the patient clinically. You can do an ultrasound, like it was mentioned that, lung ultrasound and cardiac ultrasound is very commonly performed in ICU these days. And, you can always do that. And if you find that the patient's getting B lines or he's not tolerating the fluid, you can always stop. But at least the plan should be to give fluid, and the suggested volume is about at least 30 mils per kilo. Okay. Now, your patient is hypotensive, you started giving fluid, and the patient is still hypotensive, right? So, when should you start a vasopressor? Now, in the earlier version of the guidelines, 5 years ago, that suggested you can start simultaneous vasopressors as well as along with the fluid bolus. But now they are suggesting that you should actually give the fluid first and then give the vasopressor. Again, there is a caveat. If the patient is unstable septic shock, then you should give vasopressor along with fluid. Okay, so why are they changed that first give fluid, then give vasopressor? Is because they feel, when they reviewed all the evidence, that the potential benefits of early vasopressors are there, of course, but in all patients. So again, the key is it's not necessary in all patients, right, to give vasopressor along with fluid. You should give vasopressor along with fluid. Definitely, if the patient has got unstable BP, very low blood pressure, not, and then you should probably give both fluid and vasopressor. But if you patient is not very hypotensive, say about 80 by 60, 90 by 60, give a little bit of, and giving fluid, patient is not, blood pressure is not dropping further, maybe you should complete the fluid infusion and then think of giving a vasopressor. And of course, they were worried about potential harms of unnecessary use of catecholamines in patients. They were probably influenced by this trial which was published a few years ago, and this was called the Clover trial, and they had 2 groups in this. So one was liberal fluid and delayed vasopressors, right, versus restrictive fluid therapy with early use of vasopressors, right? So there were 2 groups of patients. So in one group, they gave fluid and they did not give vasopressors till the fluid resuscitation was complete. Okay. Of course, they gave vasopressors if the patient needed rescue, the BP remained very low, the systolic pressure remained very low, below 70, the lactates remained high. Then, of course, they gave vasopressor only the rescue. But otherwise, they waited to give the 2 liters of fluid, okay, and then they gave the vasopressor if the patient did not require more fluid. Right? On the other hand, in the restrictive group, they gave very restricted fluids, and they started vasopressors early, and they gave fluids only again if the certain conditions were met. So essentially, fluid first, followed by vasopressor. So liberal fluid, delayed vasopressor, restricted fluid, early vasopressor, and they found no difference in outcomes. So maybe that's one of the studies which sort of influenced their recommendation. But I think the bottom line is, start the fluid. If you find the patient is not doing well, please start a vasopressor. And if the patient is doing reasonably okay, not crashing, then maybe you could wait till the fluid is over and then decide whether you want to give vasopressor or not. Now, remember, you need to give vasopressor early. And what is recommended now is that you can start the noradrenaline, which is the vasopressor of choice, but start the vasopressor peripherally through a peripheral line. You can do it through a peripheral line. There is no need to initially take a central venous access to give the vasopressor. So don't delay a vasopressor if it is required for the central venous access. And so go ahead and give the vasopressor through a peripheral vein. Of course, at some stage, if you find the vasopressor are required for a longer period, or if the vasopressors are going up, after some time, you can of course put in a central line and then give the vasopressor. But the initial vasopressors can be given through a peripheral IV. What should be your blood pressure target? Now the blood pressure target which is suggested is a mean arterial pressure, and mean arterial pressure, is from the arterial line. Of course, you can read it off directly. The non-invasive blood pressure also gives you a mean arterial pressure reading, and they suggest that your initial target. Remember, we are talking of the initial target should be about 65 millimeters of mercury. Okay. Now, the normal mean arterial pressure in most of us, if you have a systolic of and diastolic of 120 by 80, is 93. That's your normal mean arterial pressure. However, you're targeting only about 65, and that is probably because the autoregulation in the microcirculation is autoregulated is say between 60 and 120 millimeters of mercury. So in other words, if your blood pressure between 60 and 120 millimeters of mercury, mean arterial pressure, your your blood flow to the tissues remains more or less the same. So the tissues auto-regulate the blood flow, and it keeps it in a sort of constant rate. If the blood pressure goes below 60, the mean arterial pressure goes below 60, then the tissue blood flow reduces, and the tissues suffer from ischemia or hypoxemia. Right? So if you keep the blood mean arterial pressure just above this range of 65, then you're probably going to be safe, and you prevent the use of excessive vasopressors or excessive fluid, in an attempt to achieve higher mean arterial pressure targets. So the initial target is a 65 millimeters of mercury. Now, a recommendation which they've made, which is a little surprising to me, is that in patients who are 65 years or older, they actually suggest a lower range. Okay, so 60 to 65, and this is based on one trial, which found that in elderly patients, the mean of 60 was better than a mean of 70. Okay, but again, remember that these are all initial targets. After that, you find your patient is still having organ dysfunction, not passing urine, lactates are remaining high, maybe you can aim for a slightly higher blood pressure. But this is the initial target. Okay. What was this target of 65 based on? A very famous trial called the Sepsis trial, where they randomized patients to a high target of 80 to 85 versus 65 to 70, and found absolutely no difference in mortality. So there is no point in trying to achieve a higher target as compared to the lower target. An interesting recommendation which they've made is that you can use either invasive or non-invasive blood pressure monitoring. Okay. Now, this may hold true for the first first couple of hours, because you may again waste time in taking arterial line. But since if you're going to start vasopressors, if you're going to do frequent blood gases, if you're going to do advanced hemodynamic monitoring, then you're going to need an arterial line. Okay, so again, see the fine print over here. Invasive blood pressure monitoring is advised in patients who require intermediate to high dose vasopressors, escalating doses, multiple vasopressors, sampling, and have NIBP measurements which are inconsistent repeated measurements. So it makes a lot of sense to put an arterial line. There is a trial which was published after these guidelines were finalized, called the EVERDAC trial, again which found no difference in mortality between patients who received non-invasive blood pressure monitoring versus invasive blood pressure monitoring. But I think the consensus would be, and even a suggestion from the guidelines, is to use invasive blood pressure monitoring, especially in the sicker patients. Okay. Now, you're going to give fluids as your resuscitation, right? So which fluid should you give? And the fluid has to be a crystalloid. I think this is almost unequivocal across all guidelines by any society that you should use crystalloids as the first line fluid for resuscitation. So there is no need to use any of the colloids, like whether it's albumin or whether it's hemexcel or whether it's gelofusin or starches. We'll come to that later. So you're going to use a crystalloid, and between, so you've got two types of crystalloids. You've got novel saline and you've got lactated ringers or other balanced solutions such as plasmonite. Now, novel saline has got a composition of 154 millimoles of sodium and 154 millimoles of chloride per liter of normal saline. And our normal sodium is 140, about 140, and the chloride is actually even lower, it's 100. In other words, there's more than 1.5 times as much chloride in normal saline as in your body, in our plasma. And that's why it's no longer, it should not be called normal saline, it's actually fairly abnormal. And one of the consequences of normal saline, when you give large volumes of normal saline, is you get hyperchloremic acidosis. And hyperchloremic acidosis is not benign. It produces an acidosis, a non-anion gap acidosis. And 2-3 things happen. One is you see an acidosis, okay, and if you just see an acidosis without analyzing it as a non-gap acidosis, you'll say, oh my God, my patient, I've given so much normal saline, he's getting worse, he's not getting better, the acidosis is worsening. And therefore, you'll give either more fluid, you'll give more vasopressor, you'll give some other dobutamine or something you will do, which is actually not required, right? The other thing, and which is also very important, is that hyperchloremic acidosis is harmful to the kidney. It reduces renal blood flow, it reduces renal function, and there were trials which have been done which showed that the incidence of acute kidney injury and the need for renal replacement therapy was higher in patients who received large volumes of normal saline. On the other hand, you've got ringalactate, which has got composition is reasonably similar to plasma as far as chloride and sodium are concerned. It also has potassium and lactate as a bicarbonate source. And you've got other balanced crystalloids, like, for example, plasmonite is one of them, stereophortin is another, and they all have lower chloride contents, and so similar to plasma, right? And the suggestion is to use balanced crystalloids over 0.9% saline, over normal saline, because they don't run the risk of hyperchloremic acidosis. And the incidence in some studies of renal dysfunction and renal replacement therapy were lower when you use balanced crystalloids. Okay, so now of course, this is for the average patient. If your patient has a need for normal saline, for example, if you've got someone who's been having a lot of vomiting, he's got gastric outlet obstruction and is vomiting, of course we're going to give him normal saline, right? So this is for the average patient who doesn't have a particular need for replacing saline, sodium and chloride. Now, again, this will largely apply for when you use larger volumes. If you use small volumes of 1 liter, 1.5 liters, it's unlikely that balanced crystalloids or normal saline will make a difference. But if you're using larger volumes, then probably balanced crystalloids have the balance would tilt in favor of balanced crystalloids. Now, they do not recommend that you give albumin along with crystalloids. Okay. Again, this is for the average sort of resuscitation. If you're giving large volumes of crystalloid, then maybe you can add albumin, and that is allowed, that is part of the recommendation as a fine print. Now, do not use starches. I don't know if anyone is using starches, Voluin or something like that. There have been enough studies which have shown that the use of starches in septic shock, in sepsis or septic shock, lead to either increased need for renal replacement therapy or even mortality. And I think universally, starches are not used in sepsis. Okay, so please do not use starch under any provocation in patients with sepsis. And they also suggest against using gelatin. Now remember, the starch recommendation has got 2 crosses, means there's a very strong evidence and a strong recommendation. And they suggest not to use gelatin because there is not much data on gelatin, and whatever data is there is not useful. It doesn't show any benefit. So they suggest, for example, gelofusin or hemexcel. They suggest using against using gelatins for resuscitation. If the patient has sepsis and traumatic brain injury, then probably normal saline is better because the sodium content being higher than that of plasma is hyperoncotic, hypertonic, and therefore does not is actually good for cerebral edema, and therefore may. On the other hand, ringer lactate contains 132 millimoles of sodium, slightly less than that of plasma, and is slightly hypo-oncotic, and therefore may not be very good in patients with cerebral edema. Okay. They do say that use of supplemental albumin may be appropriate for patients who have already received large crystallite volumes, and definitely in patients with cirrhosis. I mean, that's we don't have to argue too much with that one. And of course, albumin again should be avoided in traumatic brain injury. Again, because albumin, if it's 4% albumin, then it sort of is hypo-oncotic and should be, it again may contribute to cerebral edema. So again, all these recommendations for the balanced crystalloids are based on a couple of meta-analyses, and this is one of them which looked at multiple studies, and they found that there is a effect of balanced crystalloids on mortality with a 14% relative risk reduction compared to normal saline. And this was a recommendation against albumin in patients with traumatic brain injury, right? Is that if you got trauma, then the outcomes are worse with 4% albumin. There's a lot of discussion of whether you should give liberal or restrictive fluid therapy. Everyone is. You've got the liberals and you've got the conservatives, right? Everywhere. It's politics and even in fluid therapy. Now, the recommendation here, again, it's a suggestion. It's right with a single tick, is that you can use either liberal or restrictive fluid strategy based on individual patient and health system factors. But the key here is, remember that all patients with sepsis or septic shock have already received 30 mils per kilo of fluid, and only after that you can think of any type of fluid resuscitation strategy. So remember, across the board, you're going to give that roughly 2 liters of fluid to a patient, and then you can think whether you need to give less fluid or more fluid, right? Depending on the situation. So please remember, liberal versus conservative approaches to fluid resuscitation is after the patient. You think about it after the patient has received the initial fluid resuscitation. Okay, so again, if you've got heart failure, you might want to restrict fluids. On the other hand, the patient is floridly septic, he's violently vasodilated, you might want to give a little bit of more fluid. Okay, now remember, these things work well, especially liberal fluid therapy, if you've got everything available. If you've got hemodynamic monitoring available, if you've got access to mechanical ventilation. If you do not have access to some of these, and this happens in some countries and in some ICUs, okay, so then you might have to go towards a conservative regime rather than a liberal regime, right? Now, this was a trial which, a classic trial, and it's a classic trial and it's called a classic trial. And I think it's a very important study. It looked at restrictive versus standard fluid therapy in patients with septic shock. Remember, again, all patients received at least 1 liter. And I think if you looked at all the data, they received close to 2.5 to 3 liters of fluid in the previous 24 hours. So they've already been partially resuscitated with fluid. Okay? So in they gave very restrictive fluid, and they gave bolus fluid. Bolus is only have a severe hypoperfusion. Okay, and the liberal therapy got a standard fluid therapy, which most of us would was considered as liberal. Okay, so restrictive versus standard fluid therapy, and there was absolutely no difference in outcome. Like I mentioned, patient had received a median of 3 liters of fluid before randomization, and after that they went into restrictive versus standard. And there was a difference in the amount of fluid they gave, but there was absolutely no difference in survival. So that's why you say you can consider either a fluid restrictive or a liberal fluids, but after you've given the initial volume of fluid. And then you can use your clinical judgment and hemodynamic monitoring to decide whether the patient needs more fluid or less fluid. And we mentioned that, in some patients or some situations, people who do not have access to invasive monitoring, patients who don't have access to invasive ventilation, you may not want to give too much fluid. And it makes a lot of sense. And this is a trial which was published a few years ago, which showed just that. And this was done, I think, in Zambia, in an ICU in Zambia. And they looked at patients with sepsis, and 107 were resuscitated as per the aggressive protocol based on the Surviving Sepsis Campaign guideline. They couldn't do CVV monitoring, but they looked at. Okay, So they give IV fluid bolus, and they monitor the JVP, the saturation, vasopressors, and blood transfusion. And 105 got the usual care, which was restrictive in their ICU. And they found a higher mortality. They tried to follow the Surviving Sepsis campaign guidelines. Basically, they did not have access to good monitoring. They didn't have access to mechanical ventilation. And it probably makes a lot of sense to be a little slow on the fluids and not push fluids to the point of heart failure or pulmonary edema or something instead of. Okay. So again, you need to tailor the fluid resuscitation to the situation. Now, once you've given that initial bolus of fluid, further fluid therapy can determine based on hemodynamic monitoring. And what they suggest is that you should use what we call as dynamic measures of fluid responsiveness to guide resuscitation as compared to static measures. Now, what do you mean by dynamic measures? So, what do you mean by fluid responsiveness? Or preload responsiveness? So, if the fluid, if after giving fluid, the cardiac output increases by say 10 to 15%, we say the patient is fluid responsive. So, we have tests which actually predict, even before you give the fluid, whether or not the patient will respond to fluid or will by increasing the cardiac output. In other words, you can predict by these tests whether the cardiac output will increase in response to fluid loading. And this is based on the Frank-Starling curve. So in patients who are on the flat part of the Frank-Starling curve, if you give fluid, the cardiac output will not increase. Patients on the steep part of Frank-Starling curve, giving fluid will increase the cardiac output. And there are various tests. All these tests, most of these tests will require an arterial line and will require the patient to be mechanically ventilated, with the exception of passive leg raising test, which we'll talk about later. But all these tests, which are based on heart-lung interactions, like the pulse pressure variation, stroke volume variation, will require the patient to be mechanically ventilated and sedated. Okay. Now, if you've got this pulse pressure variation in a mechanically ventilated patient, all you need is an arterial line, and most of these modern multi-para monitors will tell you, display the pulse pressure variation, and if the pulse pressure variation is more than 13%, so there's a swing in the arterial trace, right? Then it tells you that this patient is likely to be fluid responsive. If there's not much swing or the pulse pressure variation is less than 13%, it tells you the patient is not fluid responsive. Okay, so this is a very simple way of doing this, and Dr. Chawla mentioned that Dr. Sheila has developed this test called tidal volume challenge. So in patients who have a low tidal volume, and maybe we can talk about it later, patients who are ventilated with a low tidal volume, less than 6 mils per kilo, then the tidal volume challenge is useful, because all these tests have been actually validated at a tidal volume of 8 ml per kilo or higher. And in the ICU, especially in patients with sepsis and ARDS, we use tidal volume which are much lower, that is 6 to 8 ml per kilo. And in such situations, the tidal volume challenge test actually helps us to detect patients who are fluid responsive. So you should use these dynamic measures. Because conventionally used and very popular methods like the CVP, they do not tell you whether the patient is going to increase the cardiac output in response to fluid. And that's why they're called static measures. They just tell you what is the pressure inside the chamber. They don't tell you anything more than that. Of course, the CP is very high, suggests there's a problem. If the CP is very, very low, 0 or something, maybe could be fluid. Intermediate values of CP can really tell you the fluids will be an issue. So that's why the static measure, dynamic measures which predict fluid responsiveness should be used. Because if the cardiac output is not going to increase the fluid, then there is no point in giving fluid, right? And there are studies which have shown that almost even patients with sepsis, about 50% of patients tend to be non-fluid responsive. 50% are fluid responsive. So if you give fluid, you could be possibly giving excessive fluid to patients who don't need it in almost half the patients. So you need to assess fluid responsiveness in these patients. Now, we're going to give the fluid, we're going to measure the blood pressure, we're going to see fluid responsiveness, okay, and we're going to look at the urine output. We also need to see whether tissues are getting adequately perfused, right? And now there are two tests which we will use, and one is the serial measurement of lactate. So like we said, the lactate tends to be high, and what's used, and so if the lactate starts reducing, we know we are doing well. If the lactate doesn't reduce or it starts going up, then maybe we are not doing a good job with resuscitation and we need to sort of check. Now, lactate means you have to do frequent blood gases, right? At least every hour or every 2 hours. But we now have a test, the capillary refill time, which actually we used to use, but now it's been validated. So the capillary refill time can be used to guide fluid resuscitation. So this is how the capillary refill is done. It's not done by pressing the. So one is you do it by pressing the nail bed, but more recently it has been done by compressing the pulp of the finger. With the pulp of the finger, press it till it blanches, and see how much time it takes for the blood for the blood flow color to return. And if it is more than 3 seconds, it suggests the perfusion is impaired. And if it is less than that, then you're okay. So if your capillary refill time was 5 or 6 seconds to start with, as you resuscitate the patient, it should start coming down to 3 seconds or less. Okay? And there was a very, very nice trial which was done here, which has been published recently, and they looked at a hemodynamic resuscitation strategy targeting capillary refill time, right, versus standard out measures that often included lactate. And what they found is that if you targeted the resuscitation to the capillary refill time, then actually the outcome was better. So as compared to standard treatment, which usually meant like looking at lactate levels. Okay, so capillary refill time is very good because now it is validated, it is proven, it is very simple, it is very cheap, right? No one is going to sponsor a trip to Switzerland for using the capillary refill time. It's something which is very, very useful, and you can do it very, very frequently at the bedside, right? And when you compare the capillary refill time and the lactate level, okay, the lactate levels are good at prognostication. So if the lactate level is very high, or it doesn't come down, or it remains high, you can say that prognosticated this patient is not going to do well. Capillary refill time is not as good for prognostication, but as a marker of resuscitation, of the efficacy of resuscitation, capillary refill time is probably superior to lactate because it's a real-time assessment. You give fluid, give a vasopressor, and you can see the capillary refill time decreasing within minutes. Lactates will take time. So real-time assessment of response to fluid and resuscitation is capillary refill time is superior to lactate, right? And lactate is affected by many other things. If you're giving adrenaline, it affects the lactate level. If you're giving, if the patient is highly septic, sepsis itself induces a rise in lactate levels apart from tissue hypoperfusion. So capillary refill time is more specific for tissue hypoperfusion. So capillary refill time, and it should be used very, very frequently in the assessment, or at least the initial few hours of resuscitation in a patient with septic shock. So the dynamics of recovery are superior, predicted with capillary refill time. So use the capillary refill time. Which vasopressor should you use? I think there's no debate that norepinephrine is the first-line agent. And after you resuscitate the patient, all that humbug which we learned when we were much younger, that it causes renal vasoconstriction, etc., doesn't happen. In fact, the renal blood flow improves and the urine output improves and renal function improves, provided you give noradrenaline in patients who are who have got adequate amount of fluid. So noradrenaline is the first-line agent. If patient doesn't improve with NORAD, then they suggest adding vasopressin. Okay. Now, what is that dose of noradrenaline at which vasopressin should be applied? I don't think there's a consensus. There is no one dose, but usually the range is anywhere between 0.2 to 0.4 or 0.5 mics per kg per minute. Okay. In that case, you add vasopressin. Some add it earlier, some add it later. But if you find that your doses of noradrenaline increasing, then you add vasopressin. And in spite of noradrenaline and vasopressin, the BP still remains low, then the suggestion is to add adrenaline. If you've got cardiac dysfunction, and today we can make out cardiac dysfunction very easily, bedside ultrasound or bedside echocardiography, and then you use either norepinephrine plus dobutamine or adrenaline as the first-line vasopressin. Okay, do not use terlipressin except in the setting of hepatorenal syndrome and cirrhosis. Methylene blue is a lot of interest, but there is insufficient evidence. And if you're desperate, by all means, you can go ahead and use methylene blue, but there is no evidence to recommend for or against methylene blue.
How many kg is?
So if you've got septic shock and cardiac dysfunction, and you've got persistent hypoperfusion after fluids, and achieving a mean blood pressure, good arterial pressure with noradrenaline or vasopressin, then you should add vasopressors. Okay, and this is usually dobutamine. Okay? And for God's sake, do not stop noradrenaline or vasopressin. Add the dobutamine to that, because remember, your dobutamine is going to vasodilate further, so you're going to need a vasopressor to maintain the blood pressure. So add dobutamine and titrate the dobutamine to the cardiac output and the noradrenaline to the blood pressure, right? And so use both simultaneous use of vasopressor and inotropes such as dobutamine. Okay, so add dobutamine to noradrenaline, or if you don't want, you can add epinephrine, adrenaline, because that's not combined effect of vasopressor and inotropes. My suggestion is against using levosimendan and against using beta blockers. There was a lot of interest in beta blockers, especially the short-acting ones like landiolol and esmolol, in treating patients with septic shock. The hypothesis was that it would sort of reactivate some of the vasopressor receptors. It would slow down the heart rate, that sort of thing. And there were some initial studies which showed that they were safe and they did reduce the heart rate. But one large recent trial of landiolol did not show any difference in outcome. And again, most of us are very uncomfortable with giving steroids to beta blockers to hypotensive patients and so on. There is insufficient evidence for oral midodrine. Sometimes we use it when patients are recovering, to quickly get the noradrenaline off a little faster, but there is no evidence, and again, there is no recommendation for midodrine. So this slide sort of summarizes the hemodynamic management, and it's a very nice slide which looks at the hemodynamic management, and I think that's a summary of what I've been saying. Many patients with sepsis and septic shock often have concomitant respiratory failure. Sometimes the respiratory condition is the cause of the sepsis. For example, community-acquired pneumonia or even a ventilator-associated pneumonia. And sometimes, they often coexist. And there was a lot of interest a few years back. In fact, there was a lot of talk that hyperoxia kills patients. Hyperoxia is very bad, and like fluids. Fluids are bad. You cut down on fluids. So oxygen is bad. You got to cut down on oxygen. And and then there were large randomized controlled trials which looked at giving usually the high oxygen targets about over 96% saturation. So give oxygen to maintain a saturation of 96% or higher. And the conservative oxygen targets were to be around between 90 to 93 or 94%, right? So again, not much separation. You're looking at 90 to 93% versus 94, versus 95, 96, 97%. Okay, and most of the studies have shown no difference whether you give higher oxygen targets or a lower oxygen target. Now, to me, it was more of relief rather than anything else, because for years we've been aiming for high oxygen targets, 96% saturation. So only in the recent years you actually come down to it. Okay, even 90 is okay, even 94 is okay, and sometimes in COVID and in severe H1N1, you said even 80 is okay. So that's okay. You can't do anything about it. But given a choice, most of us would aim for a target of 94, 95, 96. So now I think we are okay with those targets. But again, why give excess oxygen when you don't need it? So even the lower targets are safe. So you can aim for an oxygen of 90% or 91 or 92%. In patients with acute hypoxic respiratory failure, 0.3. So I think they've just changed it to IV corticosteroids should be used in patients with septic shock. They have septic shock and they are on vasopressor and maybe increasing vasopressors, go ahead and use steroids. A funny recommendation is against the use of antipyretic therapy for the purpose of improving clinical outcomes. And the logic is that there is no difference in survival. But I don't think when we give paracetamol to any patient, we are looking at improvement in survival. What we are just looking at is more comfort to the patient. We also feel better if the patient doesn't have fever. The family feels better when the fever is not there. Okay, so they say don't. But if you can give paracetamol for pain, discomfort, etc., etc. So basically, you can use paracetamol, but don't expect any outcome to improve in that. What they're worried about is that you suppress the fever and you may miss an infection. But I think if you already got an a fever, you're already suspecting infection. So I don't think I would miss much. So I'm not very happy with this recommendation, but I guess someone very influential on the panel wanted something like this.
Dr. Divatia, excuse me, if you could summarize this so we can take some questions.
Okay, so these are the things we should not use: vitamin C, immunoglobulin, etc., etc. Okay, and I think I'll just skip all this. Renal replace, these are all standard which have been there for the last many years. Don't use early RRT. You can use it a little later. Restrictive hemoglobin targets, early enteral nutrition, DVT prophylaxis, especially with low molecular weight heparin, stress prophylaxis with proton pump inhibitors, and recommend discussing goals of care and prognosis with patients and families. Okay. You should start addressing these things within 72 hours of admission to the ICU. Thank you very much for listening.
Thank you very much, Dr. Divatia, for a very comprehensive overview of the topic. And sorry we had to cut it short because there are many questions in the chat and we need some time for discussion. So I request both the speakers to come on the screen, and perhaps I will start with you, Dr. Chawla. So you talked about early recognition of sepsis, and this is really a challenge. And as you mentioned, QSOFA is no longer recommended, and you talked about various scoring systems, Muse, etc. So tell me practically, how do you go about with the initial early recognition of sepsis? I mean, what do you use? Do you use any scoring system, or is it just clinical assessment, or what do you recommend? Sorry, you're muted, I think. Dr. Chawla, you're muted, I think.
Sorry. So, we don't use any score, but I think this News2 scores looks very exciting. And I was just thinking that probably this has a very high sensitivity and specificity. When the QSOFA we were using, but after it was regarded as not that sensitive, then now we will probably be using News2. I think one of these can guide nurses, the other residents who suspect the sepsis early, because many a times the problem in the hospital is that the sepsis is recognized late and the patient comes crashing to the ICU. So that kind of thing can be avoided, outreach, and so I think that we would probably be using News2. We have started code sepsis, but News2 we are still not using.
Yeah. So either you or Aakanksha can take this. About therapeutic drug monitoring. So few centers have this, but I'm sure you do at Apollo. And so which are the drugs for which you can you tell me practically how you would do this? When would you send the test? And if you can give it by example, perhaps Aakanksha, you can take this. Specific to therapeutic, you could probably give an example of a drug and how you would contextualize it clinically for sending therapeutic drug monitoring.
I think it's more important these days. It is recommended for vancomycin, aminoglycosides, beta-lactams, but most of the time we have till now so far used it for vancomycin.
Yeah.
And, it is important because it helps you to further decide about the dosing. Sometimes there is a possibility of the toxicity. So I think that is what is. I mean, I only have experience with vancomycin, so I think that is the only place where we've actually used therapeutic drug monitoring. It's not that readily available. Of course, we do have the option of sending it at Apollo, but it does take a little while also, ma'am, to come back. So just solely relying on therapeutic drug monitoring is still a challenge.
Right.
The other thing is they are expensive also, and the turnaround time. And you have to get multiple drug monitoring. One is if you are using AUC by MIC, then you really require to do it repeatedly, and then only can be really perfect in this. So this is and they are very expensive. We have for vancomycin in the voriconazole. Some places have for the other aminoglycosides, but still it is coming up. And I think once they are reachable, then we will be using these. As of now, they are not used that often.
Yeah, I think the cost and also the turnaround time is really the challenges that we face. I was speaking to some clinicians from the Netherlands, and they were telling me that they routinely use therapeutic drug monitoring in their practice. So I was very impressed by that. Dr. Divatia, do you have any experience with this, or can you give us with an example, how you would maybe for vancomycin use therapeutic drug monitoring, and when you would send a sample and.
So if you're using a drug like vancomycin, then the conventional practice is to send what we call as trough levels, and the trough level is sent before the next dose is due. So if you had a lab which gave you very sort of very rapid turnover, so if you send it 3-4 hours prior to the next dose and you got your results within 1 or 2 hours, you would know whether to give the dose. And I think the trough level, if I'm not mistaken, is 10 or 15 milligrams per liter, whatever the unit is, 10 to 15. And if it is more than that, you don't give it. If it is less, if it's like at or below the trough level, you go and give the next dose. So if you have TDM for vancomycin, then you would use vancomycin in that way. And similarly for aminoglycosides. So
right. So while we're on the topic of septic shock, I want to ask you, because there's a lot of interest in capillary refill time now. It's simple, easy to do at the bedside, and it's become very attractive. But these two, lactates and capillary refill time, work in two different ways. And are they interchangeable? Because a lot of people think that, okay, after Andromeda Shock 1 and Andromeda Shock 2, studies, people feel that, okay, I can just do capillary refill time. I don't need to use lactate. So what would be your take on this for the clinician at the bedside? How to integrate capillary refill time and lactate while managing a patient in septic shock?
Yeah. So I think that's a great question. And I think we should go away from this mindset of dumping something when something new comes in. Now, like you mentioned, lactate reflects the metabolic abnormalities. One contribution is to the anaerobic metabolism, which can happen with hypoperfusion. But lactate also reflects some aerobic increases in lactate, especially in sepsis, where the enzymes which pyruvate dehydrogenase, which pushes pyruvate into the Krebs cycle, is reduced and activity is reduced. So the sympathetic activity also pushes the lactate level up. White cell metabolism pushes the lactate level up. So there's a lot of anaerobic causes as well. So the lactate level reflects, one is the hypoperfusion, and it also reflects the severity of the metabolic abnormality of sepsis. So high lactate levels coming down with resuscitation, the anaerobic metabolism will be the anaerobic metabolism is getting better, but you could still have percently high lactate because sepsis is very severe. So it reflects both the severity of sepsis and the hemodynamic abnormality. You're looking at, so lactate partially addresses hemodynamics, but capillary refill is very specific to hemodynamics.
Right. So I think you've answered pretty well. So if I get that, sorry.
No, one more thing. 1/3 of patients with sepsis have a normal capillary refill time. So in those patients, you cannot use the capillary refill time. I mean, it doesn't exist, right? The capillary refill time is not with septic shock, but then you're stuck with using lactate.
Yeah, so I think you've answered this, and for the really nicely, and for the clinician of the bedside, if I understand correctly, you would do both to start with. Lactate will give a very good idea of prognostication. Capillary refill time is real time, so you would look at this from time to time, and also look at the lactate clearance. So I think it's not one or the other, but you need to integrate both while managing septic shock. And coming to you, Dr. Chawla and Dr. Aakanksha, I want to ask you a question about looking at de-escalating your antimicrobials. Dr. Chawla, you talked about 7 days for pneumonia and 10 days if it was a more severe infection. So would you wait for microbiology data before you stop the antimicrobials? Do you look at procalcitonin? How do you decide on this? Because we're very, we are very rapid in starting the antimicrobial, but often stopping or at least narrowing down is not something that is done very frequently. So what would be your
usually about 48 to 72 hours. And by the time microbiology results have come, and you know whether patient has deteriorated or patient has, and if there is a source control, you looked into this, they all support narrow therapy, and that's the time you start de-escalating. Because once you've got a culture, there is no need to cover for everything. Then you can narrow down, and we do it. I mean, it is all, you have to believe yourself, you have to believe your lab, then you are able to do it. And I think the problem is that we want, my patient is getting better, so let me continue everything. But in that process, by giving a broad spectrum antibiotics, you are eradicating all the organism, and there is a selection pressure on the resistant organism. And when another person in that ICU get infection, he get infection with the resistant organism, and that's how the MDR develops. So we should try and go mathematically or rationally and try and de-escalate the drugs.
So it's all about antimicrobial stewardship. It's a balance between getting the right antibiotic and effective treatment versus antimicrobial resistance. Thank you. So I want to ask you, if I may, Aakanksha, something about molecular rapid diagnostic tests. So where are we today with this? I mean, are there any tests that are currently being done, and how much do we rely on this? And, where is this going?
We do have a very wide range of rapid molecular tests. In fact, we've had a session and we've had a very extensive discussion on it. So yes, ma'am, for the upper respiratory viral infections, we have the upper respiratory pathogen panel, then we have a pneumonia panel, we have a gastrointestinal panel, the meningitis panel. So of course they are available, they are rapid, they give you quick results, but then you do not forget your culture and antibiotic susceptibility testing, because that is equally important, yes. And then I think it is very important to correlate it to the clinical syndrome that you're treating, not just send in a blind sample because your patient came in with some lower respiratory tract symptoms, and if you've got an Acinetobacter on it, you just start treating. You just don't do that. You have to correlate it clinically and send in your cultures, because cultures and antibiotic susceptibility testing still remains the standard.
So if I understand correctly, you would send your rapid molecular diagnostic tests, and along with that, you would also send your cultures.
Yes, ma'am. And of course, ma'am, when the patient is very sick, it does help you initiate targeted therapy initially.
Right,
quickly,
right.
of course.
Yeah, because time is the essence. Okay, we have very short on time, but Dr. Divatia, I want to ask you, the targets in especially the elderly population, the 60 to 65, and they said they had a range because they said it was difficult to meet one number, and that's why they've kept a range of 60 to 65. And as you rightly mentioned, it's a little disturbing because a lot of the elderly patients are hypertensive as well. So if you wanted to individualize this in terms of an elderly patient, how would you do this at the bedside?
So I think in any patient, like I said, this is an initial target. And then once you set a target of 60, once you achieve a target of 60 or 65 and the patient's relatively stable, then you see how the patient is doing. If he's clinically getting better, lactates are coming down, he's making urine, I guess you can remain at that level. If he's not doing well and he's got a history of hypertension and he's got a history of some mild chronic kidney disease, maybe you can step up the target and then see what happens. So I don't think there is one size fits all, but like I mentioned, these are initial targets. Subsequently, you modify as per how the patient is progressing.
Right. And about giving steroids, and we didn't touch on steroids. So in septic shock, would you initiate them early or only if there's refractory septic shock? Or I know the the evidence is not very strong, but what would you recommend at the bedside?
So I would not give it the moment shock was diagnosed. I would not give steroids the moment septic shock is diagnosed. I give noradrenaline. And if the patient had a very small dose, I might not give. But if I find that I'm escalating the dose of noradrenaline beyond my, we start about, the way we prepare it's about 10 ml per hour. Go beyond that, I would definitely steroids.
And
if we went on steroids.
Right. So one last question to you is about albumin. So initially we were using a lot of albumin for resuscitation. So you mentioned that it would be only now in the context of a cirrhotic patient or in a patient in whom you've used large volumes of fluid for resuscitation, and the patient is not retaining the fluid and is extravasating and blood pressure is not being maintained. In this kind of setting, how... firstly, when do you initiate it, and what is the concentration of the albumin that you use? Can you just throw some light on that, please?
So if you're giving albumin for resuscitation, we're looking at 4 or 5% albumin, whatever was available. Now the recommendation was made keeping into account the fact that there is no convincing mortality benefit with albumin, and also the cost and availability of albumin. Right now, if you're in a research setting like Apollo Hospital or something, and a patient, maybe you can use or Lilavati maybe, but we're not as rich as Delhi. So, so you could use albumin, but again, don't use albumin as a primary fluid. The primary fluid is still going to be a crystalloid. Then maybe after 2 liters you're uncomfortable, you could add albumin. In a poorer setting, you might wait for 3 liters or 4 liters before you add albumin.
And what concentration?
So for acute resuscitation, 4 or 5% albumin, but it is not uncommon for people to use 20% albumin at low rate for a period of time, and that's not resuscitation. That is fluid therapy, not resuscitation.
Right. Okay, so there's still more questions coming in, but in the interest of time, I'll wind up asking the same question to all of you. It's a very interesting question that's come in the chat. What is the single most important practice in current sepsis management that is likely to be abandoned in the next decade? So I just want you to give us a thought and let me know answer.
I think the fixed volume fluid resuscitation strategies are likely to be replaced by individualized hemodynamic guided therapy. I think this will definitely disappear.
That's very interesting because it's the most controversial recommendation of the Surviving Sepsis Campaign guideline with the least evidence. Yeah, Dr. Divatia.
Yeah, so I think anything that is fixed is going to go away.
Okay, so it's all going to be individualized, personalized.
All will be should be guided by TDM. Maybe we'll have inline sensors.
So that will make it very difficult for the clinician of the bedside because you'll have to be there at the bedside and individualize for every patient.
Yeah. If you want to be a clinician, you better be at the bedside.
Okay. Dr. Aakanksha Chawla, what do you think?
I think I have to agree with Dr. Chawla sir and Dr. Divatia sir.
I'm to agree with that.
I have to because what they've said is very right, ma'am. I think anything that is fixed is going to change over time because, ma'am, things change so quickly when you're bedside. So fixed principles are sometimes difficult to follow when you are practically managing a patient on the bedside. So most of the time, I think there is going to be change in that as well.
So very interesting. So in the interest of time, we'll have to wind up. We have 3 very engaging speakers, and we've had excellent discussion and talks. And I'm sure these discussions will continue. And I want to thank Dr. Rajesh Chawla and Dr. Aakanksha Chawla for having me here, and to all the attendees for patiently listening. And it's been please have a great evening. Thank you very much.
So with this, I would like to thank Dr. Sheila Myatra for moderating this session. She's a very busy person nowadays. And Dr. Divatia, my friend, who has taken out time from his busy schedule and has given an excellent lecture on septic shock. And Dr. Aakanksha, as usual, she is doing a lot of labor, I know, because every week she has to take a lecture. And also, she tries to cover things which were not covered, because that is another thing she has been doing. I think the delegates know this very well. I would also like to thank the Hexicon for conducting this, the Science for supporting this event, and the almost 1,300 people are still sitting. Thank you so much. This program is successful because of you guys. Thank you very much. See you next time. And we have the next session on the ventilator-associated pneumonia. Same time, 7:30 on the 9th of June. So see you guys. Thank you very much. Good night.
Thank you very much.
Thank you. Thank you for joining, sir. Thank you.